I'm actually going to go ahead and share the slides on behalf of Dr. Emily Frosch. So Dr. Frosch is going to be talking with us today on a primer on Maryland's mental health system of care for youth and families. Dr. Frosch is an associate professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. Before we get started today, I wanted to share a little bit of information about our organization, BHIPP, and what we do. Maryland BHIPP stands for Maryland Behavioral Health Integration in Pediatric Primary Care. And our goal is to offer support to pediatric primary care providers. We offer a number of different services across Maryland, including a telephone consultation warm line. That is a peer-to-peer line where pediatric primary care providers and now emergency department providers can call and consult with our team of child psychiatrists, psychologists, and social workers. We also offer resource and referral support to those providers as well. We offer a number of free training and educational opportunities, such as today's training. We also partner with Salisbury University and Morgan State University to offer social work co-location for social work graduate students who are placed in pediatric primary care practices across Maryland and receive an intensive training with us. We have an ECHO, which is another intensive mentoring program that we offer in a web-based format. And we do offer some direct telemental health services, such as telepsychiatry as well. This particular initiative is sponsored through a grant from the Health Resources and Services Administration, HRSA. Our organization is a partnership among University of Maryland School of Medicine, Johns Hopkins School of Medicine, Salisbury University, and Morgan State University. And without further ado, I'd like to turn it over to Dr. Frosch. Just a moment.
Okay, can you hear me now?
I can.
Okay. I apologize, everybody. Technical difficulties are real. Is it possible for me to share slides instead of you? Because no.
I don't believe so.
No.
I'm happy to advance your slides for you.
Okay. All right, because we'll have to toggle back and forth then between some things, but okay.
You let me know how I can help. And I'm
okay. All right. So why don't we go ahead and start, everybody? Hi, I apologize again for the delay. I have no disclosures, as you can see. And then on the next slide has the learning objectives that you hopefully saw, which is why you came to the webinar in the first place. So we are going to talk through different types of services and think about how to move from one to the other, and also just think through what general resources there are in the state of Maryland. Next. So this is just the general outline of what we'll hopefully accomplish today. We're going to talk through dilemmas, and I have a list, but I'm sure everybody on this call can add to the list of dilemmas that we face in thinking about resources for kids and families. We'll talk about the different kinds of providers and different levels of care, and then try as hard as we can to define what each level can and maybe cannot offer, and think about how kids move between the different levels. And then if we have time, hopefully we'll get through a case scenario. Next. So when we think about the dilemmas, you know, it's both good and bad, I guess, that there are a variety of providers and a variety of settings, and a lot of different disciplines contribute. But sometimes that can also lead to confusion about what it is that's happening. In addition, funding streams may change. And so programs that we become very familiar with and comfortable with and we really refer to frequently can sometimes just suddenly close if they lose their funding stream. And that can be frustrating. In addition, there may be new ones that have opened that we don't know about yet because it's not always easy to know. I think the issue around availability and affordability is a chronic issue. Where is the resource located? And you'll see as we go further into this that there are not good distribution of services across the state. Does a program offer tele? Does it only do in person? Is it in or not in an insurance network and things like that? And so although there is state oversight, there really is no centralized source of statewide information. There's no one page you can just Google and get everything you need. And so that makes it particularly challenging for any of us who are trying to help kids and families figure out how to navigate the mental health care system. Next. So I guess in a good way, a couple of years ago, the Maryland Health Association did a study of what is it that contributes to delays in discharge of emotional behavioral health patients in emergency departments. And you can see the main findings. And I highlighted the last one because I think it's what we experience as child mental health cliniicians, that if you are a kid or a teenager, you are going to have twice as long a delay in an ED setting. And it has to do with access to resources. And that is very challenging. Next slide. And in their report, which is publicly available, they talk very specifically about the lack of options for kids and the way in which that increases the length of stay in an ED. And I think most of us would agree that an emergency department in general is a difficult place to be no matter what's going on. But certainly if you're a youngster having emotional behavioral difficulties, it is not an optimal place to spend too much time. Next. So the good news is there are a lot of people doing a lot of different things that care about kids and families with emotional behavioral difficulties. And so you can see on this list that there are a lot of different disciplines that contribute to the care for kids in our state, which is really quite remarkable. Each discipline has, different practice definitions, different scope of practice, and within each practice parameter, within each discipline, there are people who do more of one thing or more of something else. And so there are overlapping skills, but there are important differences in the type of training, focus, and scope of practice. Ideally, we all come together and make an amazing team. Next slide. And this is just a visual that allows you to think about it in a slightly different way. And you'll notice that everybody except the life coach, that first greenish box, bluish green box, everybody else is state regulated. And that's important. It lists what the focus is, but I think that, many people would say that assessment is also part of what they do, and as well as therapy. And I think it only lists medication for psychiatrists, but I think most people would say that they do assessment and formulation as well as psychopharm interventions. I think what's tricky is that when you look at the number of providers of these different disciplines, and I'll just speak at least for child psychiatrists in the state of Maryland. So in the country, there are 8,300 practicing child psychiatrists. That does not mean they all see youngsters though, right? Or do outpatient work or things like that. In the state of Maryland, there are 1.34 million kids under the age of 18. There are 365 child psychiatrists. The average age is 52. So we're probably not keeping pace with the need. And I think, historically, child and adolescent psychiatry has been the #1 underserved workforce for all physicians. And we also know that there's about the average delay to getting care is 8 to 10 years between symptom onset and intervention. Well, from our perspective, that's an entire lifetime for the kids that we work with. So this is really hard. And I think this is why everybody's often feeling very frustrated. So next slide. So to move to talk a little bit about the different levels of care, you know, what you see there on the left is different levels of the office practice, community clinics, school-based mental health, and really moving on up through the most intensive kinds of services. And then if you click one more time, Megan.
Nope.
Thanks. On the right-hand side are other kinds of services, mobile treatment, urgent or crisis centers, and emergency departments that interface back and forth with the column on the left in different ways. So that's sort of the horizontal. In addition, there are vertical provider systems, if you will. So there are large organizations that offer multiple levels of care. You know, and I've listed a few, but you know, there are ones that have inpatient, outpatient, day programs, and other kinds of services all within their own programmatic continuum. And then there are programs that are single levels of care everywhere. Next. This is a graphic that we're going to come back to over and again through the hour because it really, what I really like about this graphic is that it helps you visualize how kids can move from the left to the right, from a lower intensity service to a higher intensity service. And this is one program's way of describing it. And I'll just point out that in that gray box that says longer term day treatment, I'm not sure we have any of those. So feel free to ignore that one because we won't be talking about it. And if anybody does know of one, let us know because that would be great to add. Next slide. And we're just going to move through the different levels of care. So, you know, the traditional office practice is often a fee-for-service model or private insurance, maybe different disciplines, either solo practice or a group. But it is, I would say, something that many youngsters and families don't have access to in our state because it is the cost and the location of those kinds of services are harder to access. Counties have community services. They may have different disciplines in those county mental health clinics. Kids may be seen for a long period of time. They may have variable availability or access to appointments, and that may impact how frequently kids can be seen. They may have capacity for multiple providers to collaborate. Next slide. Now, Megan, if you can open this link, that would be optimal.
Sure. Give me just one moment.
Okay. This is a centralized, what she's going to open, if cross your fingers it works, is a centralized list that you can look county by county at different resources. And I can't promise that it is 100% up to date. There we go. Perfect. If you scroll down and I don't know, pick one, say pick Wicomico County down at the bottom, and you can open it and then click on the bottom one. Yeah, just click on that. And it will pull up within each county, if you scroll down to show different kinds of resources that are specific to that county. And you know, you all may already know all these, but I think it's a helpful way to get familiar with what exists where you are, because that's what we're going to try to connect any given family to. Okay, now we can go back to the slides. And I think somebody is putting these links in the chats. So
yeah, that's right.
Thank you. Thank you, Naomi. All right, so we're back to this graphic again. And then if we go to the next, we're going to move up a little bit. In some ways, we're going to move up a little bit. In some ways, not. You know, school-based mental health is a very varied resource. And for many kids and families, it serves the purpose of community clinic or office practice, if you will. Many schools in this state, we're fortunate in that way, have school-based clinicians, typically a counselor or a social worker, sometimes multiple, that can provide direct care in the school. Some schools have access to prescribing, either from a child psychiatrist, nurse practitioner, or a psych NP. And these clinicians can provide primary, secondary, and tertiary prevention efforts. So a primary prevention effort would be helping teach the teachers how to have a positive milieu in their classroom, how to do general information sharing without any targets. It's just trying to improve the general well-being in the building and educate the other adults that are there to support youngsters. Secondary intervention really refers to identifying risks and intervening. So say there's a teacher who knows that a youngster, maybe a parent died of COVID, and they can connect that youngster to the counselor before there are problems, and they can do targeted intervention in that way. Tertiary prevention has more to do with once a child is really having trouble, say a youngster needs to step out of school and go into the hospital for something, and then they're going to come back in, and helping with that transition back in can be a really important part of what the school-based mental health service can help us with. So the school mental health folks are incredible resources. And I hope you all, I think some of you are them, and I'm grateful for that. But hopefully people know how to access them in their area. Click again for me. There are also after-school programs that may be in a school, although they're often not in the school itself. These are typically after school for a few hours. They could be a few hours every day or a few hours a couple of days a week. They tend to offer a variety of therapeutic activities, but it's not really focused on high intensity intervention. They might see a psychologist or a nurse practitioner or psychiatrist once a week. It's really more about group and developing social skills and maintaining self-regulation and emotional control. And it's typically an add-on to either a youngster who's in a school-based program or in a community clinic and needs a little bit more to be able to keep them doing okay, rather than needing to go to a higher level service. Next. Again, I'm going to ask you to click on that link that's at the bottom. And this is the Maryland schools page. And what I want you to see is that even on the landing page for Maryland Public Schools, there's quite a lot about mental health.
Here we go.
Okay, so this is the landing page for the Department of Education, and you can see that school mental health is right there. When you go to About Us, that's what's there. And if you go to the right under Student Services and Strategic Planning and click on that link, and then scroll down, you'll see that they have quite a number of things that you can resource. They have tools and other kinds of things under the mental health. You can see that we would probably consider some of the things that are above the mental health line also relevant, under culture and climate. I think that's also relevant to mental health, bullying, and prevention. And, if you want to just pick on one of those, like maybe pick on school mental health and open that. And it'll walk you through different kinds of resources and toolkits that you can access. Okay, so now we're going to go back to the slides. Sorry.
No problem.
Back and forth.
Okay.
And then you can click to the next one and then the one after that, because that's what you showed. All right, so we're back to this visual. And next, we're going up or to the right on that slide, and we're going to talk a little bit about partial hospitalization programs. So sometimes they're called day hospitals, and that's because the kids spend the day there instead of in school. And they are typically marked present from a public school standpoint because teachers from the school system can come in and teach them there. So that can be really important for kids and families. It's typically 8 to 3 or 9 to 3, something like that, 5 days a week. It does require families to participate. They do see a psychologist or a psych NP or a physician once a day, typically. There are groups and multidisciplinary teams that are doing individual work, group work, as well as medication management as needed, and family work. Kids and families can stay in a program like this, typically 1 to 3 weeks, and it can be used if a youngster is in a clinic. Maybe they've started in the after-school program and it's still not getting better. So this is a little bit more intense service. that they can get before needing to go to the hospital. In addition, sometimes we use it when kids come out of the hospital so that they're not going from a 24/7 care setting into once a week or maybe even once every other week kind of therapy and follow up, but they can do a little bit of a wean, if you will, from the intensity of the service. These tend to be planned admissions or urgent, but not emergent admissions. Next slide. So this is a map of where the partial hospitalization programs and day programs are in our state. And unfortunately, you'll see there's a pretty significant concentration along the I-95 corridor, which leaves the western part of Maryland and the Eastern Shore bereft of this as a resource because they do typically require transportation. There are a few that will offer transportation, but it has to be within a small radius. And so it's really not practical for a family that lives either in Western Maryland or on the Eastern Shore to drive every day back and forth into that Baltimore, Washington area. So that is, although we're talking about it as a great resource, it doesn't mean it's available to where a lot of the kids are that need services, which is a real frustration. Next. So if you remember from that slide where I had the two different types of the left column and the right column, if we think about urgent care, crisis, and walk-in, this is very variable by county. Typically, these points of contact are one time to get connected. It's sort of like an in-person version of BHIPP, if you will, where you go and they help figure out what you need and where you could go. And if you go to the next slide, this is the state distribution of emergency departments and urgent care centers. Now, you'll see that there's still not great distribution. If you look at Southern and Western Maryland, you'll see they have very few. But it's even worse than this graph would suggest because all that's listed in those urgent care centers on the right there, those are all medical. That's like right time pediatrics, nighttime pediatrics. Those do not have mental health resources. So that's a challenge again. Next slide. This is an example of if you Google, psychiatric urgent care, Shepherd Pratt has a number of locations where they have walk-in urgent care settings. And I won't make Megan toggle back and forth to the website, but because I see Naomi put it in the chat, but there are a variety of options. They have different locations, and that's the kind of thing that you would see if there is urgent care or crisis in your community, that it is very clear about how to access, what the hours are, what insurance they take. They try to make it quite easy to get the information that you need. Next. All right, so we're going to keep moving to the right here. Next. So if we talk about inpatient care, this really is 24/7 care for acute illness and safety concerns. It's a multidisciplinary team. Length of stay is very short, given how ill youngsters need to be to get to an inpatient unit, right? So what's hard about this is that it's really an ICU care setting. And what I mean by that is if you think about when a person is in a medical ICU or a pediatric ICU, they leave the ICU, they're still pretty sick. They're just not as sick. So similarly, when youngsters are on inpatient psychiatry units, it is really targeted at stabilization, which is different than robust treatment to the point of wellness. So this can be very upsetting for kids and families, especially for families, and sometimes also very frustrating for people in the outpatient side who don't have the kind of resources in their community or very easy to access that would help that youngster stay more stable. So it's both a wonderful resource, but also a challenging resource in that way. Next slide, or click again. So I have residential treatment center here, and we'll talk a little bit about it later. But although it is 24/7 care, it is not accessible in any kind of an acute situation. So even though we often think that this is what a child and family could most benefit from, it's a complicated process to access for a variety of reasons. And we'll get to that a little bit later. Next slide. So this is a map of where the Maryland Child and Adolescent Acute Psychiatric Hospitalization units are. You'll see once again that Western Maryland and the Eastern Shore are blank. And that's a problem, as you all well know. And so it's a problem not only for ease of access and ease of admission, but also thinking about for the family who needs to come to visit or to be in a family meeting. It ends up a lot more televisits, things like that. But that is hard on the youngster, but also hard on the family. And maybe they don't have easy transportation. And so it creates additional layer of adversity for some of our kids and families, which is counterintuitive to what we're trying to do when we hospitalize a youngster. Next. There are some resources in Delaware, and I have these on the map here. You know, for some people on the Eastern Shore, this is probably closer than going over the bridge and getting downtown. So it's something to think about, and I think people do use those resources. Next slide. So this is a little bit hard to read because it's a lot of words on the slide, but this is a list of all of the hospitals in Maryland that will take youngsters for psychiatric hospitalization. I want to point out a couple of things that are here. The first is that you'll see that 3 of them, so MedStar, Montgomery General, Carroll County, and Calvert Health, they take adolescents 13 and above, but they are on a floor with adults. And I think that that is complicated for a lot of our youngsters who, particularly if you're thinking about a 13 or 14-year-old who may have difficulties because maybe they have cognitive limitations or expressive and receptive language difficulties. They may be physically mature, but otherwise not so mature. They may have a history of trauma. And to put them on a unit with adults with major psychiatric illness could be scary for the kids, but also for the families. And the last thing we want to do is have somebody's possible first experience with mental health care be so scary that they don't want to come back. That feels like we're working at cross purposes in some ways. So the other thing I want to draw people's attention to on this slide is the column that's labeled legal status. And you'll see that some places take voluntary only. That means with consent of the guardian. And others take both voluntary patients and what's certified, so involuntary admissions. And again, if you think about the units that take adults, many places are also take involuntary patients. And I think that adds to the level of potential severity of illness and whatnot. And I see chats popping up there. University of Maryland is not on this list, and you are correct in pointing that out. It's because the list came from University of Maryland of where they send kids, so that is an error on my part. But absolutely, University of Maryland does have a child inpatient unit. Okay, next. So when we think about the emergency department, we know that it is used. Obviously, we know kids are sitting in EDs. We send kids to EDs because it is the setting of last resort. Click. And it's the setting of last resort for a variety of reasons. One is sometimes we can't access resources after hours. And that is very hard because sometimes problems happen in the middle of the night or after school or in the evening. And if clinics are closed, families don't really have many other options. And often clinic phone lines will say, if this is an after hours emergency, please go to your closest emergency department for understandable reasons. There are acute safety reasons why it can be very important and appropriate to go to the ED. Sometimes kids go to the ED when families just don't know what else to do. They're on a million waiting lists for this program or that program, and the kid is continuing to be unwell and unsafe and distressed, and they don't know what else to do. Sometimes we send kids to the ED because we're not sure what else should be done, and we need another pair of eyes and ears to help us think about it. I will say that just as a caveat, I think people are very aware of this, but sometimes sending kids to the ED frequently or even admitting kids frequently can unintentionally reinforce the maladaptive coping behaviors that we're trying to extinguish, right? So if kids learn, because kids may be very psychiatrically ill, but they are also really smart and fast learners, that if we communicate that every time they throw their desk when they get frustrated at school, they're going to end up in the ED and maybe get admitted. If they don't like being at school for whatever reason, that behavior may increase. So there is, we are unintentionally reinforcing that as an adaptive mechanism because it removes the noxious stimuli as far as the youngster is concerned. They may not like being in the ED either, but it may be less unpleasant than feeling humiliated and dumb. Most kids would rather be naughty than dumb. And so they will create a distraction to us that we then have to take seriously. But it's just a caveat for us to be aware of. Click. So when we think about the staffing, I showed you that list of urgent cares and EDs. None of the urgent cares have psychiatric services, right? Some of the EDs do. Some of you on this call are probably ED-based behavioral healthcare workers, which thank you, because it is a tough job. And I think that, even fewer of the EDs have in-house child psychiatrists. And, I think in reality, it's probably only University of Maryland and Hopkins, downtown Hopkins, that have in-house child psychiatrists because they have fellowship training programs where people have to learn that. But it's very challenging to do that. Luckily, I think the psych NPs are playing a really important role in filling an important gap that we have. But I think it's challenging because, as you all have probably figured out by now, emergency departments do not love our patients. And the reason they don't is because they tend to require security, which impacts the bottom line, and they stay too long compared to the average non-psychiatrically ill emergency department patient. And so all of that impacts emergency departments in ways that we don't even know about, but is a challenge for them. Click. So from a resource standpoint, most EDs have social workers. They are not necessarily psychiatric social workers, but hopefully they can help with referrals and connections. And then I'll just put a plug in here for calling the BHIPP crisis line, because that is what we are designed to help you all with. And then click. Just a reminder, and I know I need this reminder frequently, that, the purpose of an emergency department is very focal. It is, do I need to admit this patient or can they be discharged? It is not about making a diagnosis or initiating treatment, which is complicated when we have kiddos that are waiting days, even occasionally weeks. Like, do they not get treatment if they're sitting in an ED waiting for an inpatient bed or waiting for another disposition? And that is a complicated dilemma that I don't think anybody has solved yet. I think that there is conversation about how do we think about initiating treatment, but that really does require having people who are comfortable prescribing and managing psychiatric dysfunction in an ED, and that is not typically the primary ED providers themselves. So again, psych NPs, social workers, psych nurses have begun to play an increasingly important role in trying to at least offer some sort of treatment. You can have a family meeting, you can do sort of crisis intervention like that. The challenge, particularly though, is that the setting itself is problematic. It's noisy, it's hectic, it can be very overstimulating, and it doesn't have access to the kinds of things that we know that our kids need in terms of a comfort room or things that can help calm them, headphones or, talking. And it's just a complicated setting to try to do treatment in, but it is a huge dilemma. Next. The good news is, I guess, is that the state has figured out that this is a big problem and are beginning to try to think statewide how to make additional crisis services available. And I just put this up there to promise you that the state is beginning to think about what do we need to do statewide to think better about emergency room diversion. Next. And, it was about a year ago that they put forward a strategic vision for this, what they call comprehensive mobile response and stabilization services for kids and families. And you can see the goals. This is publicly available. It's easy to Google, and hopefully Naomi will include that in the chat. But it hasn't yet turned into actual resources, but I think that, again, we are lucky to be in a state where the state has noticed and the state cares. And I think that is really something, because that is not true for children with mental health problems in all states, unfortunately. Next slide. So in addition, they are taking this new approach. Hopefully people have heard about 988, which is a national number. Maryland had 211, and both work for a while until 988 is all situated. It is important for patients and families to know about, and it is designed for patients or a family member to call. But I think, if we have somebody in our office, that this could be a useful resource as well. Next slide. I won't make Megan open the link, but so basically what it does is it connects you to, and if anybody on the call has used it or has experience with it, please put something in the chat, because it'd be great to hear about it. But it does connect you to a national lifeline service that will connect to somebody in Maryland. There are 8 call centers, and they do phone-based support, and they can connect you to local resources. And it's behavioral health, but also suicide, substance, any kind of problem that we would consider would fit into this. Next. So when you call, you get a message and it's routed, and you actually speak to a human, they swear, who answers the phone and listens to what's going on and tries to figure out what's needed. If for some reason all the Maryland lines are full, you go to a national person who will work with you, and they are in both English and Spanish. And it is the call centers are distributed so that they can connect you to local resources wherever you're calling from. So hopefully this could be part 1 of ER diversion. So the goal is to try to have this be a crisis, so that the 911 call is saved for true life-threatening emergencies. So I'm going to switch gears a little bit on the next slide, which is, why would care escalate? What happens? What is it that goes on with kids and families when we're all working really hard to manage them, that it could escalate to a higher level? And I like to keep things simple. It makes it easier for me to remember things. So I think of the 3 A's. So the first one is anxiety. And that is that somebody in the system is increasingly anxious about something. And it might be the kid now refusing to go to school at all because they're too anxious. Could be the caregiver. Maybe it's their own anxiety. Maybe it's anxiety about the youngster. It could be us as the clinician, who really is just, I can't sleep at night. That's a good sign that something's not going well. The teacher, somebody could be very worried about it. And that increase in distress is going to tip the system over. And so that would be a reason why somebody needs to go to a higher level of care. And you can see, it could be related to illness. And as I mentioned, whose illness is it? Could be related to temperament. And again, whose temperament is it? Somebody's having some behavior issues driven by anxiety. Could be anybody's. And then maybe something terrible happened in addition to that has really just led to too much distress. Next. The next A is anger. And this is, somebody in the system is getting too angry to keep everybody safe at home. Or in the care setting they're in. So sometimes it's the youngster, sometimes it's a parent or the caregiver. Sometimes we're feeling so frustrated with what's happening that this isn't going to continue to work. And we may not be angry at the youngster or at the family, just at the system. And we need to get more people involved to help. And so if you click one more time, yeah, there. So this, again, could be related to irritability and anger of an affective illness or a psychotic illness. And again, I'd want to know whose illness. Sometimes, our kids are not always the one in the system who are the most ill. And sometimes they are the ticket to health for the whole family. And we need to be mindful of that. And then the third A, one more click, is ability. Sometimes even if they're not that anxious, not that angry, somebody in the system is not able, despite best efforts, we still can't manage to keep this youngster and family safe. Parents may be doing their best, but it may not be enough. That kiddo may need industrial strength parenting that family is not up to, maybe because of their own, if you click again, their own illness, their own stressors, their own responsibilities that make it harder to manage that particular youngster. So I like to keep things simple. Those are the way I think about it in terms of the big picture of what could be going on that means something has to change. The next slide has more to do with what happens that they go to a higher level. And here there are three typical things. So something happens, a bad event usually, a suicide attempt or a threat, maybe something impulsive or unpredictable. They were a fight that escalated from words to physicality, or they've run away and came home. Something obviously happened to them and we're worried about their safety. Another is just a failure of progress, and they're getting worse despite all the things we're doing. Maybe they've been in the school-based mental health and an after-school program, and we brought in mobile crisis. It's still not helping enough. And now they're they're continuing to get worse. And, maybe that affective illness, maybe now they won't get out of bed, they won't eat or drink, and maybe we're worried that they could be becoming catatonic. And so maybe we need a higher level of care. And then the last one that I think is important to think about is, and it's sort of similar to failure to progress or worsening, but sometimes we really don't understand what's happening. Despite our best efforts to formulate the case, reformulate the case, nothing is working. And maybe we just need a fresh set of eyes in a safe environment to try to figure out, what do we try next? Because I think we need to be able to collaborate and lean on each other when things aren't going so well. So next. So I wanted to just talk, I'm going to try to talk a little faster, what can we expect from higher levels of care? So we talked a little bit about IOPs and after school programs. These are planned admissions, so they're not that helpful in an emergency, but sometimes it can be helpful when you first meet a kid and family and you think that there could be potential for periodic decompensation, to put them on waiting lists early. So that if they call you and say, do you need it? We have an opening, you're next on our waiting list, you can say, no, thank you. But at least it's sort of you're in the pipeline. Next. And the same is true. Obviously, it's not available in every region of the state, but it is day program, partial hospitalization programs are planned admissions. But similarly, if you start working with a youngster in an outpatient setting and you think, oh, this could go south quickly, put them on waiting lists, because I think that can speed things up. And then urgent care and crisis is going to be available throughout. Next. An inpatient unit, typically kids are admitted either from an emergency department or from a day hospital or even from another care setting potentially. They may or may not be connected to outpatient care when they come in. A lot of kids come to the ED, it may be their first pass at mental health treatment. Length of stay is anywhere from about 3 days to maybe 10 days. There are some outliers that stay a very long time. They're typically waiting for placement of some kind, but that isn't what the unit is designed to do. There is a multidisciplinary team and they focus on the things that you can see there. I think discharge planning always includes a formalized safety plan. And I think that's something that can be very helpful to the receiving team. Next. So I mentioned residential treatment center. I don't really want to spend a lot of time on it because it's not something that any of us can access very easily. It's a complicated process. Patients have to be accepted and often they have to go on an interview. And if you can just imagine what it's like to be a youngster who needs a residential treatment facility, how that goes on an interview is a complex process. But typically kids need to fail multiple times in other placements and other levels of care to demonstrate a need for an RTC. It does require funding either from DHMH, public schools, or from social services. There are some families that private pay. Length of stay typically ranges from 6 weeks to 6 months. You know, it used to be, we talked about 18 months to 2 years, but that's long gone. It's a multidisciplinary team. They can do family work, therapeutic milieu, medication management, and they also focus on discharge planning from day one. Next. So how do you get to a lower level of care? This is a lot less consistent, I would say. Next. It really depends on a lot of factors. It depends what the target symptoms are. And it is not uncommon that the target symptoms that we see in the outpatient world, that the family sees, that the school sees, are not seen in an inpatient unit. They're away from their normal environment. It's highly structured. For all kinds of reasons, we may not see it in an inpatient setting. And if the unit does not see the symptoms, it's very hard to keep a youngster in the hospital. So that can be very challenging to everybody involved, family, outpatient team, because it's hard to justify an admission if we don't see behaviors or symptoms to target. Sometimes families are discharged because they are not adherent to the program. You know, is the youth coming to the day program? Is the family coming for family meetings? And I think this is a complex one because, like, I hate the word non-compliant. For me, that means that we didn't do our job to understand what the barriers were for this family to be able to access that service. But sometimes families don't participate even when they have the means to access. And so understanding before somebody starts in a program, are they really committed to doing what's needed there or not? Sometimes, unfortunately, there are insurance constraints, and then we get involved with doc-to-doc reviews and things like that. And sometimes we win, sometimes we lose. That's a tough one. Sometimes the program has its own parameters that have more to do with program issues than individual patients and situations. Ideally, the best reason for moving to a lower level of care is progress. But I think it's more complicated than that, to be honest. Next slide. All right, this is that same graphic, and you'll see there are a bazillion arrows because kids can move all over the place. And I think that sometimes movement is a measure of success. They're moving maybe to a lower, or we're increasing the services because the family is finally ready for them. And sometimes it can be a measure that things aren't going so well. So movement does not necessarily mean anything other than it's what the kiddo needed at that moment in time. Next. But of course, there are a lot of added dilemmas, right? There are waiting lists for almost every program everywhere, which is exhausting. This is why kids are waiting in the emergency department. There are programs that have a lot of inclusion and exclusion criteria. So if, you know, a lot of our kids have a lot of psychiatric dysfunction, but they may also smoke marijuana. And if that's an exclusion criteria, that's going to be hard. Insurance barriers, geographic barriers, you saw the maps. Not everybody has access to the same types of services. Sometimes there are barriers within the youth and the family that we have to work through. They don't want that service. They don't want in-home services, things like that. Then we want to make sure that what the kiddos need aligns with the skills of the clinicians in that program. And I think that's sometimes works and sometimes it doesn't. And you guys can probably add a lot more dilemmas to this. I'm very mindful of the time. We have about 5 minutes left. We do have a case, but I don't know that if we have time for that or if we want to go to some questions. I defer to preferences.
I don't see anything in the chat. I think, I'm not sure how long your case example will take, Dr. Frosch, but I think we could get started with it and then move.
Okay. All right, we'll go next. All right, so this was a 13-year-old cisgender boy, family history of maternal anxiety, personal history of language issues, school learning issues, social work intervention at school, lots of moves and financial stressors. Went to a new middle school, the IEP did not follow, and now he's having escalating disruptive behaviors at school and at home. He has been diagnosed with ADHD and depressive disorder, but he's not on any meds. Click. Hopefully this case sounds familiar to things that you all see. Fell out of treatment when the family moved, but his new middle school has a school-based mental health clinician who saw him weekly for several weeks, but has begun to get worried about his mood as he seems really angry and short-fused, and referred him to start an after-school program. And so he attended that program and initially seemed to be doing better, or certainly no worse. It seemed to be holding him. And after about a week of going, he started skipping transportation and walking home saying he didn't want to go back. And then he stopped going to school. Next. So he was referred to a day program where he miraculously started the very next week. I know that's not realistic. In the day hospital, they noted that he was sullen, minimally cooperative with group activities. His mother missed the first family meeting, came to the second one, but was late. And he looked more irritable on the day his mother missed the meeting. He was marginally cooperative in individual sessions, seemed easily confused and overwhelmed by group activities, but did engage more with art-based activities. Next. In week 2, he didn't come to the program on Monday. Outreach to the family led to learning he'd stayed out all night Friday, but they didn't know where, and had come home Saturday, refusing to say what happened. His mother was distraught and took him to the closest ED, where he was still waiting for an evaluation. And his mother said she can't handle him at home, and sharing he's been increasingly aggressive with his younger sister, who's actually in the same grade in school. They're a year apart, but he repeated. Okay, so you can see, hopefully this resonates with people's experiences, but he used outpatient, school mental health, after school plus school mental health, a day program, and the ED. And the reason click for his movement was combinations of adherence and lack of improvement. And you can see anxiety, anger, and ability were all 3 probably relevant for what was going on. So next. Just to summarize, I think the system of care in Maryland is complex. It's multi-layered, that is both rich with resources in a lot of ways, but also hard to navigate. I think the challenge of matching services with youth and families in the locations needed and in the time frame needed are still quite significant barriers. But I'll just put in a plug that BHIPP is a great resource to help connect and identify options. And there we go.
All right.
Made it under the wire.
You did. Thank you so much, Dr. Frosch. That was a great presentation. I know Naomi has been putting a number of our links in the chat, and we're also going to be sending out resources after today's presentation, as well as a link to the CME survey so that you can receive CMEs or CEUs for attending today. I am available to stay on. If folks have questions, you can go ahead and put them in the chat, and I will monitor that here, and I'm happy to read the question aloud, and Dr. Frosch and I will do our best to answer. No questions so far. Naomi is going to be sending out the CME and CEU certificates 3 business days after you complete your evaluation. We're also going to be sending out a recording of today's session along with the handouts that I mentioned. Lots of compliments, Dr. Frosch. Thank you so much for this great presentation. I enjoyed this incredible and needed presentation. Thank you for an informative presentation. Thank you, very informative.
Great.
Right. Well, I will stay on in case there's any questions, but I know it's 1 o'clock. We want to be respectful of people's time on their lunch hour. Thank you so much to everyone for joining us today.
Bye-bye.
All right, it looks like there's no other questions. I'm going to go ahead and close the meeting. Please reach out to us at BHIP if we can help with anything, and we'll be in touch with those resources in a few days.